with great pleasure that I'm going to introduce the last speaker of this session, Professor Justin Mason. Professor Mason is the Professor of Vascular Rheumatology at Imperial College. He's an interesting rheumatologist, I think, in that he's focusing a lot of his life on endothelial dysfunction, which we traditionally think of cardiology or maybe a diabetes domain. You would probably disagree, but you've done an amazing, obviously, academic career, made an amazing academic career out of it, and we are very much looking forward to your lecture on inflammation as a cardiovascular disease accelerator. Thank you.
Thank you very much indeed. And thank you for a lovely introduction. Please excuse my infirmity. I've got, I think, a viral labyrinthitis, which is, so I'm going to sit, if I may, during the presentation. So I feel very privileged to sneak in around the corner as a rheumatologist into this meeting, and I've listened to two wonderful lectures already this morning. And I'm going to focus on inflammation for fairly obvious reasons. I have a few declarations of interest, which are listed here. So I think I probably don't need to convince this audience that there is at least a role for inflammation in the process of atherogenesis. And for the sake of the lecture, I'm going to divide atherogenesis into primary, and that's in patients without a systemic inflammatory disease, and then use the term secondary for atherosclerosis associated with systemic inflammation. And so the question overall I want to address is this a therapeutic target? And if so, which aspects of the inflammatory process are a target? And are they the same for primary and secondary atherogenesis? So the two PET images on the left here illustrate inflammation within the atherogenic process. The first is an FDG PET scan showing increased FDG avidity around the inner curve of the aorta and around the brachiocephalic branch point, sites where atherosclerosis develop. And that's from Mark Dweck and colleagues, and Jason Tarkin and Jason Rudd produced the second image, which is using a different PET ligand, gallium dotatate, showing focal uptake in the coronary arteries, binding predominantly SSR2 receptor on activated macrophages. And I've used this cartoon from Libby and Schoenlein's beautiful review to try and illustrate the variety of pro-inflammatory processes that are going on here. So it might start, for example, with activated platelets and the release of some chemokines, smooth muscle cell proliferation with migration and clonal expansion, as well as phenotypic switching, which proves important to smooth muscle-like cells and macrophage-like smooth muscle cells. And these may proliferate, but they may also undergo cell death and begin to form the necrotic core. There are other important inflammatory processes, of course, recruitment of monocytes and neutrophils into the subintimal space. And here at sites of disturbed blood flow, for example, neutrophil activation and the release of nets can lead to denudation of the endothelium, so-called plaque erosion, as well as further activation of monocytes within the plaque and pushing us towards a necrotic core and an unstable plaque. And all or none of these may prove to be viable targets for therapy. So as a rheumatologist, I've been seeing, and these are patients I've seen over the years, a variety of patients in whom we can now treat inflammation fairly effectively. But although we've recognized their risk of premature cardiovascular disease, which can be up to 2 to 3-fold in those with rheumatoid, as high as 10-fold in some studies of SLE, and 2-fold, say, in psoriasis or psoriatic arthropathy, we're still not at all effective, I think, in specifically targeting this as a risk for these patients. And, of course, there are other cardiovascular diseases which are increased in frequency in systemic rheumatic diseases, but I'm going to focus on the process of atherogenesis. So the questions really, I think, are why would these patients have perhaps more widespread or more aggressive atherogenesis? Is this because from a relatively early age, particularly in the lupus, for example, they're seeing widespread endothelial dysfunction secondary to endothelial injury? Is the process of atherogenesis really accelerated in these patients? Is it different from that we see in primary atherogenesis? Or is it more that the plaque is inherently unstable and more likely to rupture? Or is there increased plaque erosion? And finally, certainly in some of these diseases, we're looking at a prothrombotic environment, which may also be contributory. So Peter Libby and I produced this slide, which in hindsight is overcomplicated, but the reason I'm using it is to illustrate the fact that these patients, the secondary patients, have accentuated traditional risk factors that need tackling, as well as immune disorders that are probably driving this process. So, for example, smoking is a marked risk factor for the development of rheumatoid arthritis. Many of these patients have physical inactivity for obvious reasons and a predisposition to insulin resistance. I'm not going to go through all the immune mechanisms. These include autoantibodies. They include different accumulation of T-cell subsets such as the CD4 positive CD28 group, an imbalance in Th17 T regulatory cells, and a variety of pro-cytokine environments, which we'll touch on in a later slide. So perhaps let's choose 3 diseases and just break them down a little bit, because I think there's a tendency for us in this setting to consider inflammation as a single entity, when, of course, as I've shown on one of the original slides, there's a variety of mechanisms at play here. And what's more, they differ between the different rheumatic diseases, and I think if we're going to see this as a therapeutic target, we need to take this into account. So there are many similarities, of course, between RA, SLE, and the vasculitides such as Takayasu's. They all have evidence for systemic inflammation. If you look with flow-mediated dilatation, for example, early in the disease course, you'll see endothelial dysfunction. If you look with PET scanning, you'll find aortitis in all of these diseases and the presence of aortic stiffness. But rheumatoid is a high CRP, high ESR illness associated with IL-1, IL-6, and TNF-alpha. Whereas lupus, you do not typically see a raised C-reactive protein. You may see an ESR, and there's an interferon gamma signature in most of the investigations that have been done to date. And finally, Takayasu's probably fits somewhere in between. It is a high CRP ESR illness. You do see IL-6 and TNF-alpha, but IL-18 is more predominant, and maybe IL-12, 23. And then they also have unique features such as joint erosion and immobility in rheumatoid, nephritis, and proteinuria in patients with lupus, as well as predisposition to metabolic syndrome. Whereas in Takayasu arthritis, I'll show later, the distortion of the arterial anatomy and disturbed flow patterns within the vasculature is another driver for atherogenesis. So we did a study many years ago now with Paolo Comici and colleagues, where we took a group of rheumatoid patients and SLE who we knew had normal epicardial coronary arteries. They'd either had a catheter study or we arranged a coronary CTA. And we compared them with age and sex matched controls and looked at changes in myocardial blood flow in response to adenosine, which you can see on the left was very significant. But grouping rheumatoids and SLE together, you see the patient group has attenuation in myocardial blood flow increase, and perhaps in this subgroup here, a really marked defect. And maybe this is a way of beginning to identify the subset of these patients who are more prone to cardiovascular disease down the line. Now, you'd need a much bigger study than this, and you'd need longer follow-up than we have, and a lot more money to do this effectively. But interestingly, a subsequent study using a rat model of collagen-induced arthritis has illustrated early disturbances in microvascular blood flow, microvascular dysfunction, and it was these rats that went on to develop evidence for early macrovascular disease and increasing aortic stiffness. So it seems possible that one might be able to take a subgroup of SLE patients and predict whom is most likely to develop cardiovascular complications. So what about the plaque itself in these patients? Is there any difference here in the plaque biology and plaque morphology? Well, there's a little bit of conflict in the data on whether there are increased numbers of plaques, but I think the evidence sort of favors the fact that, for example, in RA and SLE, you are more likely to have more plaque. And this study, published in 2013, looked at 150 rheumatoids and 150 age and sex-matched controls, and indeed shows that there was 71% plaque in the RA patients versus 45% in the controls. Multi-vessel disease was more prevalent. The plaque characteristics were more severe in terms of stenosis, severity scores. And interestingly, the joint disease activity indices correlated with the presence of non-calcified and mixed higher risk plaque. And a couple of subsequent studies looking more directly at the plaque using an immunohistochemistry type index or ultrasound grayscale medium both suggests that plaques in RA patients are more vulnerable. They're more likely to rupture, at least on the basis of those indices. And Peter Libby highlighted to me, when we were discussing these issues, a very interesting paper published 10 years ago now in Nature, which maybe gives us a clue. This is a murine model using atherosclerosis prone animals in which various distant events, it might be an infection, might have been an angioplasty or surgical intervention, led to an echo effect in which there was a pro-inflammatory, pro-progressive stimulus on distal plaque. Now, in someone with systemic inflammatory disease who has an intercurrent infection, who is already primed to inflammatory responses, one might imagine that a constant echo effect driving plaque biology may favor the vulnerability that we saw in the previous studies. So what are we doing about it? Are we making any difference? And since the advent of biological therapies, now anti-TNF inhibitors particularly, but also anti-IL-6 and the other agents we use, we are now beginning to see, I think, some benefit on cardiovascular outcomes. This first came up in the British Society of Rheumatology Biologics Registry, where they took a subset of patients who responded very effectively in terms of rheumatoid disease activity to the introduction of an anti-TNF agent within the first 6 months of treatment. And then they began to see a reduction in the risk of myocardial infarction in these patients. Subsequent studies from Meeker and colleagues illustrated that the commonly used antirheumatic drug methotrexate can also, in responders, reduce the risk of cardiovascular disease and stroke by around 20%. And much bigger subsequent studies, such as this one of 25,000 patients from Boston, has shown that, again, if you're effective in bringing down disease activity, by which I mean joint disease activity, you reduce the risk of future cardiovascular events by 21%. And again, if you do subset analysis and take those who do not respond to treatment and have high activity joint disease, compared to those that go into remission, you can reduce cardiovascular events by 50%. And subsequent meta-analyses shown at the bottom of the slide illustrate very similar data and intriguingly suggest that if patients are on long-term corticosteroids, the opposite effect is seen and cardiovascular events are more frequent. But just before we start congratulating ourselves and thinking we're on top of all of this, inflammation is the key, 2 subsequent studies came out over the last 2 or 3 years which suggest that some of the benefits seen for methotrexate in the upper study in terms of cardiovascular events and admissions to heart failure, both of which came down substantially, and in the lower study looking at endothelial function and changes in response to treatment, they see benefits in both studies, but when they control for disease activity, they find that a lot of the benefit is irrespective of rheumatoid disease activity. So there's clearly a number of issues here, and I think it shows that our understanding of the mechanistic nature of some of these processes is still relatively poor, and we've got to be looking at both inflammatory and non-inflammatory pathways. So in the second half, I'm going to target primary atherosclerosis and whether inflammation plays a role and how we may attack it in the future. So the sort of studies that I've illustrated to you in systemic inflammatory disease in rheumatology, at least I like to think, led to some of the interest in use of biologic agents and methotrexate, for example, in primary atherosclerosis. And you'll all be aware of the CANTOR study led by Paul Ridker and colleagues, which was really a seminal study. But there's a number of key points that we need to look at here. Firstly, very careful patient selection was done for this study. And the patients had to have, using the high sensitivity CRP assay, a CRP of greater than or equal to 2 to gain entrance to the study. The patients had had previous myocardial infarction or triple vessel coronary artery disease. And the benefits were seen, 30 to 40% reductions in circulating IL-6, for example, and in the CRP level, with 17% reduction in cardiovascular events. But these benefits were seen in patients whose CRP fell from the mean for the study of 4.1 to less than 2. So there had to be a demonstrable benefit in terms of inflammation reduction to see a benefit of the monoclonal antibody canakinumab that was targeting interleukin-1 beta. But nonetheless, an important study in terms of the relationship between inflammation and atherothrombosis. Now, somewhat in parallel, Paul Ridker also ran a study of low-dose methotrexate, by which I mean 20 to 25 milligrams a week, based on the data from the rheumatoid studies. But it was much more difficult to get funding for this study. It was less well-funded. They didn't have the scope to do very careful patient selection. And the mean CRP in this group was 1.53. The study was stopped prematurely because there was no obvious benefit, no reduction in IL-1 beta, interleukin-6, or CRP, and no reduction in cardiovascular events. So let's just think about this in a little bit more detail. Paul Ridker has come up with this very nice concept, and we've heard data about this earlier on today, and allowing for the fact that it's extremely difficult to achieve adequate suppression of cholesterol. If indeed that can be achieved, we're left with a group of people who are still at high risk of a cardiovascular event. There is those who Paul Ridker would describe as having residual cholesterol risk, in other words, cholesterol suppression or LDL cholesterol suppression is less optimal than it might be, and so they might be targeted for PCSK9 inhibitors. But the group I want to focus on is the one he describes as having residual inflammatory risk, who have good lipid control, but are left with a CRP similar to that was seen in the CANTOS trial. So maybe this is the group we should be targeting for immunomodulation. And again, I highlight the fact that the SERT CRP fits very nicely with the residual cholesterol risk, whereas the CANTOS CRP fits with the residual inflammatory risk. So one might argue, and almost certainly we'll never see, that if one had switched the two populations around of CANTOS and SERT, maybe we would have seen a benefit for methotrexate, but not for IL-1 beta in the SERT study. And I doubt whether that study will ever be done. The other point I want to mention in the difference between SERT and the other studies is that the mean age of intervention in the SERT study was 66 years of age. These patients had pre-existing coronary disease and myocardial infarction. They probably had low-grade smoldering inflammation, which was local, and it was accumulative. Whereas if you look at the rheumatoid studies, most patients develop rheumatoid in the third and fourth decade, and if you introduce methotrexate at that stage, one might imagine at least that the process of atherogenesis was much earlier in the pathway. And they have systemic inflammation, they have perhaps this echo effect, and they have different plaque biology. So we may be comparing apples with pears here, and I think we should be careful about throwing out methotrexate as a potential agent going forward. So realistically, and I'd be interested to hear from the cardiologist in the audience, is there an appetite and is there a role for adjunctive therapy? Because this is always going to be adjunctive therapy in addition to standard of care and would require selection of those with residual inflammatory risk. Well, I think there might be. And the quite surprising but quite gratifying results from the studies of colchicine, which I've summarized here, Colcolt, Lodoco-2, and Lodoco, suggests that low-dose colchicine, 0.5 milligrams per day, can have effects on cardiovascular events, both relatively immediately following myocardial infarction, but also in stable and chronic cardiovascular disease. So I think it would require a personalized medicine approach. We'd have to select out those with residual inflammation. Probably we'd want to be targeting younger patients, although with additional risk factors, maybe diabetes, maybe hyperlipidemia. But is this going to be acceptable to patients? We've heard from our GP colleague it's difficult to persuade them to take statins. Are they going to want to take long-term colchicine or indeed methotrexate? A cardiologist are they going to want to prescribe it and monitor it? And what are the optimal agents? We need further clinical trials. So I think it's still in the balance. So finally then, I want to turn to how we might make our life easier in this setting going forward. And Professor Dienfield mentioned the impact here that imaging might play. And so I just wanted to highlight some of that because I think this is a key point. So here's a study from Nihal Mehta and colleagues at the NIH looking at the associated predisposition of atherosclerosis in patients with psoriasis and the impact of biologic therapy, predominantly anti-TNF, but there are also some patients with anti-IL-17 and anti-IL-23. And I've just taken one figure from Nihal's paper, and that is to show that on those who received the biologic, there was a reduction in total plaque, there was an increase in dense calcified plaque, and a reduction in non-calcified plaque, which was not seen in those patients who did not receive the biologic. So really intriguing evidence that these treatments can modify plaque biology. And I also wanted to touch on perivascular adipose tissue. And this is work from Nihal Mehta's group, but also Haris Antoniadis in the University of Oxford, using conventional coronary CTA scanning to look at perivascular fat and its impact on the process of atherogenesis. So in the normal coronary artery, for example, there's healthy perivascular fat with mature lipid-laden adipocytes, and using fat attenuation index mapping, you can get a readout for the health of the perivascular fat. In diseased, inflamed vasculature, maybe an atherosclerotic disease or indeed a systemic inflammatory disease, the lipids and the fat layer is changed, there are lipid-poor adipocytes, and a marked change in the FIA. Now these are two-way pathways. So there is crosstalk between the adipose tissue and the vessel, both in the healthy state and in the inflamed vasculature. And bidirectional crosstalk between adipokines and the vessel wall, and in the diseased vessel, release of pro-inflammatory cytokines, changing the fat morphology. So if you look at the relationship between the FIA and cardiac mortality, there's really some quite striking findings. And again, this is the work from the Antoniadis group in the University of Oxford. And they've shown that the measurement of the FIA adds a substantial amount of data above and beyond that is given to us from conventional assessment of the coronary CTA results. And this is shown here, where you take someone with a normal FIA and a low-risk plaque as the index, and then they were looking at normal FIA with a high-risk plaque, low FIA with low-risk plaque, and high FIA with a high-risk plaque. And progressively, you see an increase in cardiac mortality associated with significant change in the FIA. And they took this forward into the CRISP CTA study, which was a large study of 2,000 participants from the US and nearly 2,000 from Germany. And this study clearly shows that change in the FIA is indicative of inflammation and the risk of cardiovascular events. It may also identify culprit lesions, so may help in patient selection. It's modifiable by effective statin therapy and indeed by the biologic drugs such as anti-TNF, and is predictive of mortality. And Haris gave me this slide of a patient of his where this impact of vulnerable lesions and predictive mortalities is very striking. A 40-year-old gentleman with atypical chest pain sent to the clinic for investigation, had a coronary CTA, and was considered a low risk of a future cardiovascular event, certainly a future fatal event. But he in fact died of an MI approximately 2 years later. And when they went back to look at his FIA, and the figures were very different. His FIA was clearly abnormal, and that increased his risk of a fatal event to 7% and may indeed have altered management. So I think this is an area of active research, but an area that may well help identify patients who might perhaps benefit from anti-inflammatory therapy. Now, we've done a little bit of work in this area with a high-risk group. We have an interest in large vessel vasculitis, and we've looked at a number of our patients in terms of their coronary artery risk, because these are young patients who often don't have symptoms, and we have been caught out by occult coronary disease. we find that more than 60% of the patients have evidence of coronary artery involvement. The majority of this is non-significant in terms of stenosis, so less than 50%, but about a quarter had significant coronary stenosis. And when we map these lesions, we see a variety of patterns. Some of the lesions are proximal in the arteries and most likely represent a direct vasculitic effect. Some of this is ostial and proximal, but about 40% have mixed diffuse disease with increased calcification, very suggestive of premature atherosclerosis. And the main coronary arteries involved were the right coronary, the left main stem, and the LAD. And here is a particularly illustrative effect, a 29-year-old lady who probably developed her Takaysu-arteritis in her mid-teens. She has very severe disease with profound stenosis of her aorta and distal occlusion, leading to pretty refractory hypertension and left ventricular hypertrophy. But she presented age 29 with pretty vague symptoms that were suggestive of breathlessness on exertion, and she has severe triple vessel coronary artery disease with a mixture of proximal lesions, again primary vasculitic probably, but also clearly secondary atherosclerosis with calcification, irregularity distally in the vessels, affecting predominantly the left main stem and proximal LAD, but also the RCA and circumflex, and presenting a very difficult clinical conundrum. Now, with the Cambridge group, we looked at some of these patients and we compared Takaysu-arteritis with primary atherosclerosis using perivascular fat analysis on the coronary CTA. And we looked at 36 with Takayasu's, with coronary artery disease, 18 without coronary artery disease, and we looked at a group of atherosclerosis patients and healthy controls. And we could stratify the patients based on the pericoronary fat, and we also used aortic fat. So TAC and CAD had the largest change in FIA, then TAC, then the coronary artery disease, and then the control, suggesting that inflammation on top was affecting the pericoronary fat. And I'm not going to go through the data in detail, but what Jason Tarkin, myself, and James Rudd were able to show is that the perivascular fat density associated with both the Takayasu clinical disease activity as measured by ITAS, but also with the CRP. There was a close association between the PCAT density and the results of the gallium dotatate scans in these patients, so linking inflammation to the changes. We felt that it was representing a recognized marker of early atherosclerosis, so again helping us to select the most vulnerable patient, and may also discriminate coronary arteritis from atherosclerosis, which is a bit of a niche challenge for those of us in the vasculitides. So finally then, looking to the future, we need better biomarkers. I know CRP is in and out and somewhat controversial. I just wanted to flag this paper from my colleague Ramsey Kamis, recently published, which took a large group of patients from trusts across London, about 250,000 initially, stratified on the basis of troponin and their high-sensitive CRP on admission, presenting with acute coronary syndromes. When they removed patients with a raised white cell count or CRP above 15, about 100,000 were left. And in this group, when they took 4 groups of CRP, less than 2, 2 to 5, 5 to 10, and 10 to 15, they show a clear association between the CRP and the 3-year cumulative mortality. If you compare the CRP with troponin, so CRP in red, troponin in blue, the troponin adds an added element in terms of cumulative mortality, and then if you retrospectively control for those that were subsequently coded as ACS, this relationship remains. So again, is this an early biomarker of those who we might target for colchicine, or one of the immunomodulatory drugs? So I'm not going to go through this in detail, but there are numerous studies, some of which are summarized here, looking at these processes and helping us understand these important relationship between inflammation and coronary artery disease going forward. Immunization, targeting plaque with nanoparticles, looking at additional biologics. Are they safer? Are they more hazardous? The same goes true for JAK inhibitors. What about targeting the inflammasome and getting better agents to do that? And also, I haven't had time to touch on clonal hematopoiesis and the relationship between that and systemic inflammatory disease and coronary vascular disease, and how that might be targeted. So I'll conclude by saying that I hope you're convinced that inflammation plays a key role in cardiovascular disease. This is multifactorial and context dependent. It's not going to be switched off by a single agent. It's multicellular. A variety of cell types are involved. I think there are probably primary and secondary forms that they may inform each other, but I think we have to accept there may be different biological processes in systemic inflammatory disease and primary atherosclerosis. I think in all of these, inflammation may act as an initiator, it may act as an accelerator, it may act as a plaque destabilizer. But our mechanistic understanding is still really too rudimentary. And we have to accept that this is a complex therapeutic target. But I strongly believe that with patient selection, as Professor Dienfield was saying, early treatment and prevention, we can, with targeted anti-inflammatory intervention, along with standard of care, we can reduce cardiovascular burden going forward. And clearly, the genomics, proteomics, metabolomics explosion is going to help point the way to thus. So I will finish there. Thank the organisers and all my colleagues who've been involved in this work. Thank you very much.